Hello, this is Miss Roberts at Southern Regional Technical College. I'm covering Module 4, which is Chapters 9 and 10 for RNSG 2910, Maternal Child. We're going to start off by going through some things in the book. This is your online ebook. I will speak out the page numbers that I'm referencing, as well as important things to know. We're going to start off on page 284 in your book. I know we covered some of this already in class, but I'm going to start back at the beginning of chapter 9, where you had that, because we were kind of rushed for time. So we talked about the external and internal stimuli. This is having to deal with the physiological transitioning of the newborn. This part here, the chemical factors, is a wink and a lollipop. This information here, where it says chemical factors that initiate respirations are hypercarbia, and we talked about that being too much CO2, acidosis, and hypoxia, which is not enough oxygen. These conditions, brought about by the stress of labor and birth, stimulate the respiratory center in the brain to initiate breathing. Hypoxia causes blood oxygen levels, which is PO2, and pH to drop. So this is important right here. Okay. We talked about the surfactant up here and what it was, that it was the glue-like substance that holds open the alveoli. Then look over on page 285, and it's discussing the thermal factors. Also, another wink and a lollipop is the drastic changes. So the drastic change in temperature, which is right here, okay, helps stimulate the initiation of respirations. Wink and a lollipop, okay. The normal range, another wink and a lollipop, is 97.7 to 98.6, okay. Another wink and a lollipop. However, to prevent cold stress and respiratory depression, the nurse immediately dries the infant and either places the infant skin to skin with the mother / partner or in a radiant warmer, okay. And then mechanical factors, which is another wink and a lollipop, is this paragraph here where it's talking about the primary mechanical factors involved in initiation. Include removing fluid from the lungs and replacing it with air, that first breath. And then the chest compression or that thoracic squeeze that occurs during vaginal birth, okay. Also increases the intrathoracic pressure, okay. The recoil of the chest wall after birth creates a negative intrathoracic pressure. This facilitates a small passive inspiration of air, which replaces the fluid that has been squeezed out. Okay. Going on down, still on page 285, under cardiopulmonary transitions, we discuss acrocyanosis, and that's with the blue color in the hands and feet, but the central body is a pink hue color, okay. That's just a term that you need to know. Other indicators, we talked about the nasal flaring, the grunting, which is, like I said, they sound like a little pig when they grunt. The retractions, and this is where the retractions, when you see the ribs as they're breathing, okay? So these are important to know as well. Okay? That's when you know a baby is in distress. Going on down, let's talk about the closure of foramen ovale. This is the flap over the septum in between the heart. And let's flip over to some of the PowerPoint, my lecture notes. This is the flap in between here, okay? And it's in your book as well. Just be familiar with that term, the closure of the ductus arteriosus, and that's the pathway between the pulmonary artery and descending aorta. Okay, so here's the pulmonary artery, okay, and so it's this closure between the aorta and the pulmonary artery, okay. Let's go on over to page 288. And there's another picture of that closure, okay? The neutral thermal environment. Again, when can a lollipop? Our normal temperature to stabilize is the 97.7 to 98.6, okay? This should happen within 2 to 3 hours after birth. Okay. Then we're discussing the physiological adaptations to heat production. Okay. And the mechanisms for neonatal heat loss. Okay. So remember we talked about the evaporation and conduction. And you know, conduction is the loss of heat to a cooler contact, such as the skin or a mattress or anything that is put on the baby, like not warm skin, but just skin to skin can actually facilitate the warming back up. But a diaper, anything like that, okay? The evaporation is, you know, just when it goes away, the baby's left out in the open, okay? Convection is the loss of heat from a warm body to cool air currents. So like ceiling fans, things like that makes the baby lose heat. And then radiation, where it's the heat loss that occurs when you transfer it between heat and another object as well. So a crib or a cold window or things like that, okay? Just be familiar with those terms. Let's look at the lab work. The ones that you should know are the bilirubin. So these here, I'm going to highlight the glucose, the hemoglobin, and the platelets. Okay, so you need to have these memorized. Okay, so if you want to take a picture of that on the screen, screenshot it, whatever you need to do, but those are the ones that you need to know. Okay. There's a video here if you want to watch it, just talking about the closure. Let's see if I can play it for you. If not, then we'll move along.
Starting with a blank page can be overwhelming. Grammarly gives you a head start. Simply type a prompt.
Alright, in this scene we're going to talk about fetal circulation. We're going to take a look at what the circulation in the fetus looks like right before it's born. So let's take a look down here. Here we have a simplified view of the circulation inside the baby. Here we have the placenta, where mommy's blood and baby's blood mix. This is essentially where the baby's blood gets oxygenated in order to provide oxygen for the baby. Here we have the liver, and here we have the heart. Here we have the umbilical vein. And the umbilical vein travels towards the liver area, where it joins with the hepatic vein. We don't want all the blood to go to the liver, because why should we waste so much oxygenated blood just on the liver? Instead, we have a bypass, and this is known as the ductus venosus. We'll see at the end how to remember that. We have the ductus venosus over here in black. It's not really black, I just made it black to make it easier to visualize. The oxygenated blood in the ductus venosus joins with the inferior vena cava over here. The inferior vena cava, of course, is deoxygenated, as it brings deoxygenated blood from the legs of the feet. And so what happens is, the ductus venosus and the inferior vena cava come together. The oxygenated blood from the ductus venosus and the deoxygenated blood from the inferior vena cava mix. And there we have mixed blood in the inferior vena cava. And it goes into the right atrium. We also notice that the superior vena cava also brings deoxygenated blood, completely deoxygenated blood, and thus it is blue, to the right atrium. So this is our first shunt, the ductus venosus. Let's talk about the second shunt. So here we have the heart, and normally, in an adult, blood travels from the right atrium to the right ventricle. In fetus, it does this as well. But this is kind of counterproductive, because what's the point of bringing blood to the right ventricle just for it to go to the lungs? The lungs are filled with water and can't do anything really for the baby. So instead, pressure builds up on the right side of the heart, as it can't make it to the constrictor arterioles in the lungs. And it gets shunted through this foramen valley, which we don't see over here because of the cross-section. We see an arrow, where blood is taken from the right atrium to the left atrium. There's a hole. Now, blood can travel from the right atrium to the left atrium to the left ventricle, and from there to the baby's body. So that's the second shunt. The blood travels through the foramen valley to allow blood to travel from the right atrium to the left atrium. Now let's talk about the third one. So here we see the pulmonary artery. In the fetus, there's a connection between the pulmonary artery and the aorta. This allows blood to travel from the pulmonary artery to the aorta. And we want this to happen because, as we mentioned, the blood in the right ventricle is oxygenated. So if we get that blood into the aorta, it can actually provide oxygenated blood to the body. This shunt, which allows blood to travel from the pulmonary artery to the aorta, is known as the ductus arteriosus. Here we have the aorta, where blood travels to the baby's body. And we also see the umbilical arteries coming off of the internal iliac artery. So just to review, we have the three shunts. We have the ductus venosus, which acts as a shortcut to carry blood from the umbilical vein to the inferior vena cava. We have the foramen valley, which allows blood to be shunted from the right atrium to the left atrium. And we have the ductus arteriosus, which allows blood to be shunted from the pulmonary artery to the aorta. Okay, now I'll come up with a fun way to remember this. So here we have a duck with a V nose. Its nose looks kind of like a V. The duck with the V nose for ductus venosus. This is going to help us remember that the vessel which brings blood from the umbilical vein to the inferior vena cava is known as the ductus venosus. Now let's go to the next one. Over here we note these four men over here in veils. Four men in veils going from the right atrium to the left atrium. Four men in veils for foramen valley. Okay, let's move on to the third one. Again, here we have the ductus arteriosus, which brought blood from the pulmonary artery to the aorta. We can imagine a duck over here who loves arteries. He's such a big artery fan that he paints himself red. He even puts hearts on himself. The duck who loves arteries for ductus arteriosus. This reminds us that the ductus arteriosus is what moves blood from the pulmonary artery to the aorta. One more time to review, we had the ductus with the V nose for ductus venosus, we had four men in veils for foramen valley, and we had the duck who loves arteries for ductus arteriosus.
Okay, so hopefully that helped you remember those, and just gives you the pathway of the heart and how it changes, transitions, okay? Moving along, this is just talking about the respirations, the onset of respirations, what actually happens. And this is in your book on figure 9.2. And that is on page 286. Okay, just going back a little bit. Alright, now we're going to go back to, or move forward to page 291. This is talking about hepatic adaptation, so the liver, how the liver adapts, okay, and how glycogen and glucose are stored. I want you to look at hypoglycemia, okay? So this is another wink and a lollipop. So the blood glucose concentration of less than 35 or plasma concentration of less than 40 is what we're looking at, okay? For anything at Archibald, it's 40 or less, okay? And I think I showed you on our slide the algorithm that Archibald uses, okay? So they screen all late preterms, which is 34 to 36 and 6, or LGA babies, which are over 90% tau for their weight, or SGA babies. So this is how they come up with what they do and when they do it, the time frame, okay? On page 291 also is this box 9-1, just to read through that, okay? These are risk factors for hypoglycemia in a newborn, okay? Here's your mnemonic if you need a tool to help you memorize that, okay? All right. Excuse me. So going back to 291 again, let's look at iron storage, okay? Iron storage happens the last few weeks of pregnancy. The body stores it, and it can play a significant role as far as what the moms eat, and then as well as the baby having iron-rich formula or iron-rich diet, okay, to prevent anemia. Hyperbilirubinemia. This is huge when we're taking care of newborns, okay, for all the different reasons. And we've talked about some of them with the blood factors causing that, the OGG and OGAs and IgMs, IgG, IgAs, so I want you to look at the term hemolysis, okay? Bilirubin is produced from hemolysis, which is the breakdown of red blood cells and hemoglobin, okay? The HbF is, which has a shorter half-life of the actually hemoglobin. It's the hemoglobin factor, okay? Be familiar with box 9-1, just different risk factors that cause the hypoglycemia, and we covered that just a second ago on the other one, but these are the reasons, okay? Let's look, continuing on to hyperbilirubinemia. Let's see. So the term jaundice, is the yellow icteric coloration of the skin, the sclera, or the mucous membrane. And remember, I told you in class about how to test because the bilirubin is caudal, so it goes down. The jaundice goes down in the body. So we start by pressing on the forehead, then the edge of the tip of the nose, then the chin, and then the chest, okay? And you're looking for that icteric color, that yellow color, after the skin blanches, okay? Let's see, for a wink and a lollipop, you have this right here. So at birth, the normal total serum bilirubin is 3 or less, okay? That's what they should be at birth. Jaundice is typically evident when the serum bilirubin levels reach approximately 4 to 6. So you're going to see some yellow sclera, some yellow tinged skin. You're going to see that icteric color. And then yellow coloration progresses caudally, remember, from the top of the head down, as it rises from to about 6 or 7, okay? Be familiar with this connectress term as well and the disposition of it, okay? And there's some factors here listed for hyperbilirubinemia. All right. This is a routine screening from Archbold as well, and how they screen for hyperbilirubinemia, just to look at all of this. The phototherapy treatment, when they start treating, and they start treating with a level over 15 or greater. Okay. And you have unconjugated and conjugated bilirubin. Okay, you're going to discuss some of this more in Med-Surg, but this is in your book, and it's important for you to understand. So I want you to be familiar with this chart right here. Okay, the increase with red blood cell destruction ends up as being unconjugated bilirubin. Excuse me. And it increases with the asphyxia, hypothermia. You remember how we talked about, can hypothermia play a role in jaundice? Absolutely. And this is what happens, okay? So unconjugated bilirubin is released, and it's combined with the glyceronic acid to form conjugated bilirubin. It then goes to the bile duct, the GI tract, as well as is absorbed through the kidneys. So they're passing this bilirubin, they're passing this bile, this yellow color, in their urine as well as their stool. But remember, it's combined with that glyceronic acid to form the conjugated bilirubin. Okay? We're flipping on over. We're going to immunological adaptation. Okay? And we're going to talk about this IgG and IgA. Okay? The IgG is the only immunoglobulin to pass through the placenta before birth. Okay? Full-term infants acquire immunity from their moms. Okay? And they pass many diseases on because of the passive immunity from their mother. So they're protected. Okay? If the mom got immunized for influenza, measles, mumps, smallpox, chickenpox, then the baby can also have some immunization into that. Does that mean the baby does not need to be immunized? No, it does not. The baby still needs to be immunized, okay? They just have a passive immunity to get them through the time period until they can be immunized, okay? So that's what the IgG is for, okay? So that means it's gone, like it's not there, all right? And let me show you this picture, okay? So it only is able to pass through the placenta, transfers of the immunoglobulin during that third trimester, okay? So going back, we're talking about IgA, okay? This is important in protecting the baby against any infections of their own, okay? So colostrum and breast milk, this is why we call that colostrum liquid gold, because it has all of those antibodies and all of that immunoglobulin in there to protect them, okay? Breast milk entering the bloodstream is only about 10%, okay? They're produced in response to infection or a virus. They're synthesized about 10 to 15 weeks, and they can actually be detected about 30 weeks, okay? IgM increased at birth. This is talking about IgM now. IgM is talking about the exposure, okay? So IgA is the local effect of what's in the intestine, and only about 10% is through the breast milk. will enter the bloodstream. IgM is when there's an infection mounting, okay? That's detectable, and it goes into action when there's something for it to fight, like a virus, infection, a pathogen, okay? So IgG, it's not there. IgA is building up resistance to an allergy, and IgM is it's fighting. All right, let's look at newborn sleep states and behavioral sleeping patterns, okay? So this chart is in your book on page 295. Under behavioral states, where it says sleep states on page 295, about halfway down of that paragraph, let's see. Right here. This is a wink and a lollipop, okay? So the periods of alertness are fairly brief during the first 2 days of life as the infant recovers from events associated with birth, okay? So they are barely awake those first couple of days. Educate your parents on that this is a normal thing for babies, okay? All right, 297 in our book. We're looking at APGAR, okay? So APGAR is a test that is done at 1 minute of age and 5 minutes of age, okay? So immediately after birth, okay? There's 5 categories. There's respiratory efforts, muscle tone, reflex irritability, and skin color, okay? They get a score of 0, 1, or 2 for each of those categories. So the best of the best would be 10. The worst of the worst would be 0, okay? We never want a 0, all right? So when an APGAR score is less than 9 at 5 minutes, we also sometimes do a 10-minute score, not always. It would necessitate for the baby to be stabilized, you know, if they're grunting or retracting or their heart rate is down less than 100, then we're going to do something, okay? Or there's going to be some type of cardiopulmonary actions by the nurse, okay? Of course, we're always going to have our blue bulb syringe or whatever color bulb syringe right next to the baby at all times, right? But this score chart right here in your book on page 297, you need to have this table 9.3 memorized, every single category memorized. You will have questions on your test on how to configure an APGAR. I gave you a sheet on that. I need you to practice more questions like that, okay? Because you'll be having to figure one out. First 5 minutes when you're doing assessing, you're doing the vital signs, you're doing, you're looking, look, listen, and feel, okay? You're drying them off. Remember that conduction, convection, a wet baby can be a sick baby, so dry the baby off. A wet baby is a cold baby, always, so dry the baby off, okay? Interventions would be to give the medicines within the first 2 hours, and we'll talk about that in a second. But the vitamin K, which is a blood clotting factor, right? Because babies are not born with blood clotting factors. That's why we give vitamin K. We also administer erythromycin in the lower conjunctival sacs, intercanthus to outer canthus. And then we also, with the parent's permission, as they signed a form, the hepatitis B vaccine if the parents want them to have that, okay? APGAR scoring. Let's watch this video.
Your child needs these 3 factors to get into an Ivy League or top 25 university.
APGAR scoring in the newborn. APGAR scoring was developed in 1953 by Dr. Virginia APGAR, who described 5 signs that could be determined easily and without interfering with the care of the infant. A rating of 0, 1, or 2 is given to each sign, depending on whether it is absent or present. A score of 10 indicates a baby in the best possible condition. The judging of the 5 objective signs is generally done at 1 minute of age after delivery and at 5 minutes of age. A score of 7 to 10 is considered normal, while 4 to 7 might require some resuscitative measure. A score of 3 and below requires immediate resuscitation. This chart indicates each of the signs and scores. APGAR scoring for newborns. The APGAR score was published in 1953. 10 years later, an acronym was reported in the Journal of the American Medical Association that helped teach the APGAR score by using the letters A, P, G, A, and R. This acronym was co-authored by Dr. Joseph Butterfield. Activity muscle tone. Muscle tone refers to the amount of active motion of the extremities. A score of 0 indicates a newborn who is limp and without movement. A score of 1 indicates a newborn has some flexion of the extremities. A score of 2 is an excellent score, which indicates spontaneous movement of arms and legs that resist extension. Pulse refers to the heart rate of the newborn during the time of scoring. The heart rate is determined by placing a stethoscope on the newborn's chest and listening for the heart rate. A score of 0 indicates that there is no heart rate. A score of 2 indicates that there is a heart rate of 100 to 140. Reflex irritability. Reflex irritability refers to a response to some form of stimulation, such as suctioning the nose and mouth. Suctioning with a bulb syringe after delivery to clear the airway often elicits a response of facial grimacing, sneezing, or coughing. A score of 0 indicates that there is no response to any stimulation. A score of 1 indicates that there is slight grimacing with no sneezing or coughing with stimulation. A score of 2 indicates that there is grimacing, sneezing, coughing, crying, or vigorous movement with stimulation. All infants are cyanotic at birth because of their high capacity for carrying oxygen and the low oxygen saturation in their blood. The disappearance of cyanosis depends on respiratory effort and heart rate. A score of 0 indicates that the infant remained gray, pale, or obviously cyanotic over the trunk and extremities. A score of 1 indicates that the infant's skin color is pink with the exception of the hands and feet. This is called acrocyanosis. Acrocyanosis is very common and can occur in spite of excellent ventilation. Most infants fall into this category. A score of 2 indicates a newborn's entire body and extremities are pink. Respiratory effort. This refers to the newborn's respiratory effort at 60 seconds and 5 minutes of age. A score of 0 indicates that there is no respiratory effort. This is referred to as apnea. A score of 1 indicates that there is irregular, shallow ventilation, or a gasp once at 30 or 45 seconds after birth. A score of 2 indicates that there is regular breathing and/or a lusty cry. You have completed this learning activity.
Okay, so hopefully that kind of explained on what you should be seeing when you give it a number. Not just memorizing the actual words, but what you would actually see when you're assessing a baby. Okay? Here's you another short acronym over there as well. Okay? Alright, so let's look at vital signs. So, at the bottom of page 298, there's box 9.3. This is a wink and a lollipop. This axillary temperature is different from what you've seen before, but I need you to know that this is okay. This is normal, okay? The big thing to know with your wink and lollipop is you're counting the heart rate for a full minute, right? And you're counting the respiratory rate for a full minute. No matter what any nurse tells you in the clinical atmosphere, you are to count 1 full minute. Alright, measuring the baby. We practice this in our skills day, but you know when you measure the baby, you measure around the head, around the nipple line, and right above the umbilicus, okay? On page 300, it gives you a chart for the normal gestational age assessment and how they fall from large, average, and small gestational age. So, also known as LGA, AGA, and SGA. Approximate or average are interchangeable. Okay? There's another parameter for normal vital signs in an infant. Okay? This is the Ballard score, the Ballard tool that we use. We do this at birth as well within the first hour. This is actually used at Archibald, and we will practice these together. We will do one of these together in clinical unless you do one on an infant at birth, okay? But this gives you a maturity rating, so you would circle if the baby was postured like this, you would circle this, and that would be a 3. Or if the square window was this picture, that would be a 4. You add up the numbers for every picture, you get a score, okay? So let's say our score is 38, okay? So we're falling right between the 35 and 40. So our gestational weeks would be about 39 weeks, okay? We compare the weeks on how they measure, because this is a physical and a neuromuscular maturity scale, according to their actual due date. And like if the mama is 38 and 6 and we got 39 on this, you know they're pretty significantly right on track, right? They're close because they tested. And sometimes you'll have one that's a week apart, and that's okay too, as long as they're not way off. You know, we have a baby that's presenting at 42 or 43 weeks and their gestational age is 35, then we got a problem. Somebody messed up some dates somewhere, right? Alright, and that's on page 301 in your book. Then it starts talking about metabolic screenings. There is a handout at the hospital that the parents are given, and it tests for over 25 congenital diseases. It explains what they do. They prick the heel on the baby and do what we call a PKU, okay? This is the measuring, and this is the handout I gave you. But the PKU is just a little test that we do. I thought I might have had a picture of it, but I don't think I do. Oh yeah, I do, right here. Alright, so it looks like this. You feel this part out, and it's got several carbon copies of it, with all the mom and the baby's information. You prick the heel on the baby, you get blood samples and 5 or 6 little circles that have to be completely saturated. You mail this off to the state, and then within 30 days they mail the results back to the pediatrician and back to the parents of the child. Okay? And to let them know, they test for cystic fibrosis, fetal ketonuria, which is what PKU stands for, maple syrup urine diseases, all type of congenital anomalies they test for. Okay? And that is, again, on page 301 in your book. All right, let's look at page 303. Just ahead, this is talking about the head-to-toe assessment, integumentary system, the different general color, jaundice. We've talked about all of this, right? Plethora is a deep purplish color, related to increased number of skin, RBCs that break down under the skin. And then you have petechiae, which are pinpoint hemorrhagic areas on the skin. Okay? Just to be familiar with those terms. Acrocyanosis, you know, this is where you have the blue feet and blue hands maybe and a pink body. Okay? If you'll look at page 303, it's about the second full paragraph that starts with physiological jaundice. Okay, about the second sentence down. It says physiological jaundice has often a non-hemolytic cause and frequently results from a failure to adequately process bilirubin from inadequate intake or elimination, birth trauma, or minor blood incompatibilities. Okay? So, key word is birth trauma. So, when a baby is bruised, that blood under the skin can cause bilirubin to form. Hence, you get a jaundice baby. Okay, the icterate comes out. All right. So that is a wink and a lollipop. Be familiar with that. Also, I think I told you this in class. You need to write this statement down. ABO incompatibility within the first 24 hours is pathologic jaundice. So ABO within the first incompatibility within the first 24 hours is pathologic jaundice. Okay? Physiologic jaundice is after 24 hours of birth. Okay? So if we have a mama and a baby that have some type of Coombs, indirect Coombs positive, then we are looking at the pathologic jaundice, because that's happened within 24 hours. It's already started before the baby's born, right? The blood incompatibility's already started before the baby's born. That's how an easy way I remember it, okay? Physiologic jaundice, such as the bruising, okay? That happens after 24 hours of birth. Okay? Alright, so a lot of cultures have infants that are born a lighter skin than what they will be. Okay? This is a Haitian baby that's light skinned. His skin will darken, or her skin will darken as they mature in age. Okay, I guess it's a her, it says female. Alright, then we have lanugo. This is the hair on the back. So when you're assessing lanugo, and of course it's on that Ballard scale, we have to assess lanugo. This is some lanugo, okay? It's the hair, the fine hair all over the body, okay? Vernix caseosa is that waxy, sticky white substance that's in all of the creases on the baby. And this serves as like a water protectant, almost like a wax to protect that skin from the amniotic fluid. Okay, that's why your babies aren't born looking like a raisin, because they have this vernix to protect their skin. Okay, milia are tiny dots on the skin, tiny little white dots. Please educate parents and family members that this is normal. Okay, they don't need to be popped or mashed or squeezed, anything like this. You can harm the baby's skin and set the baby up for infection, so don't touch those. Okay, some more pictures. All right, Mongolian spots. So this is melanocytosis, and this is just congenital. It's very much related to ethnicity. African Americans, Asians, Hispanics will see this more than the Caucasian race. Okay, stork bites. This is just a little spot on the back of the neck. Sometimes it can be lower than that, but usually it's around the neck. I have one myself, and it's normal. It will not fade. Some of the Mongolian spots will fade, but the stork bites usually do not fade. Okay. You have the different terms I told you in class I want you to kind of read about. Okay. Tangletic nevus is the red birthmark, like an angel kiss or stork. That's the stork bite. Nevus folliculosus is the strawberry mark. And that, let's see, I thought I had a picture of that one. Right here. This is the strawberry mark. Okay. This is the brown nevi. And the nevus flammeus is the port wine stain. Okay. Usually fades a little bit, but not always. All right. Right now I want you to look on page 307. The different suture lines. So your suture line on infant's head is straight down the middle, or it should be. Okay. This is a normal head. All right. Periosteum is covering that suture line, of course, and then with the scalp. But you know, the sutures are there where the baby can be born vaginally. The bones cross over each other, squeeze in, and then come back out after delivery. Okay, so B is actually called a caput saccadium, and it is where the hematoma or soft tissue edema crosses over the suture line. Okay. Cephalohematoma is where it does not cross the suture line. Okay. It's a subperiosteal hemorrhage, hematoma, and it does not cross. So the caput saccadium does cross, the cephalohematoma does not cross. Okay. This is a wink and a lollipop. You need to know the difference. Okay. Know the difference in these right here. All right. Especially B and C. Of course, A is normal, but know those terms. Okay. Know which one crosses and which one does not cross. Okay. Page 308. All right. This is just talking about natal teeth. Babies are born with teeth sometimes. I went back for a week checkup after I had my first child, and there was a baby in the waiting room that had 4 teeth. born on the same day as my son. And that's the first time I had seen that. But yes, if she was breastfeeding, best wishes, because you know that's kind of hard when your baby's got teeth, especially that young, when they don't have any control, or not much control anyway. So assess the palate. Okay, when you're assessing, we talked about this, to assess the palate. So you're looking, Epstein pearls are right here. That's just the little parts of the gum that they disappear, but no big deal. But when you're assessing the lip. Of course, you can see a cleft lip, right? But you can't always see a cleft palate. So you need to be sticking a gloved finger in that baby's mouth to assess for a cleft palate. Okay. Assessing the ears and eyes lining up. Okay. To determine if they have some type of congenital issue going on. Okay. Let's see. Newborn hearing screenings are done routinely. Let me go back. In the United States, so you're going to always have a baby that's got a hearing screening before they actually go home. This is a wink and a lollipop. Okay. They must have a hearing screening before they leave. If they have one and they fail, or they fail even one ear, they come back to the hospital within 2 weeks and they have that repeated. And if they still fail, they are referred to an audiologist for further studies. Okay? On page 311, this is discussing the cardiovascular system, some of the respiratory system. If you'll look at this box where it says patient education, okay, this is a wink and a lollipop. So how to recognize breathing difficulties, okay? Know how to recognize breathing difficulties, wink and a lollipop, okay? Flare nostrils. You can write nasal flaring out beside that, just a different term, but means the same thing. Okay, so nasal flaring out beside here. And this is on page 311. All right. Now getting into the cardiovascular portion. Wink and a lollipop here. For infants, a normal heart rate should be what? 120 to 160 beats a minute. 160 or over is called tachycardia. Okay. But 120 to 160 is normal. Okay. You may or may not hear about murmurs when you're listening to the heartbeat. You may hear a murmur, and always remember, the louder the murmur, the smaller the hole. Okay, let me say that again. The louder the murmur, the smaller the hole. The larger the murmur, the softer the sound. Okay? That's just like you get a high-pitched squeak when you're blowing through a tight balloon, right? And it's hard to blow through. If you get a big balloon, you're not going to hear that sound because it's easier to blow through. Okay? So the larger the hole, the softer the sound. The larger the sound, the smaller the hole. There's critical congenital heart disease screenings, CCHD. You will see that on your, or have seen that on your clinical paperwork. Okay? So this is a condition where the baby is tested to see the oxygen level and make sure that the baby has accurate oxygen, all over the body. Okay, so we're testing O2 sats maybe on a right foot and a right hand, or blood pressure cuff on a right foot and a left hand, or left foot and left hand. So they can do it on the same sides, and then they pick one that they do it as opposite sides. Okay, and that's on page 311. All right, let's look on page 312. Common findings with the heart. Page 312, under common findings, that first paragraph about halfway down, it's talking about murmurs. Okay, we just talked about murmurs a little bit, but this is a wink and a lollipop. Okay, so murmurs are characterized by a sound best heard at the sternal border at the second to third intercostal space on the left side, that grows louder during systole. Although a heart sound arises from a PDA, may be heard initially. Remember, that's patent ductus arteriosus, right? But the sound can disappear in 2 to 3 days when the ductus closes. We've been to clinical, and I've been a nurse and seen this a whole lot. You go and you listen to that baby first thing in the morning, and you hear a murmur. By the time the pediatrician gets there, or a couple hours, 2 or 3 hours later, you go back and listen for that same murmur, and it's gone. That means that ductus has closed, and that's what we want to happen. Okay? If the murmur remains audible after the second day of life and intensifies with a whoosh sound, further investigation is warranted and may indicate the presence of another type of heart lesion. So we may have some other issues going on. A lot of times, and 99% of the time, when a baby has a murmur and that it's heard by several nurses, because we all get together and we all check behind each other. That's what nurses do, right? And then when the physician comes in, pediatrician comes in, and they hear the murmur as well, he will order an echocardiogram on that baby. Okay, and they happen a lot. So it's common. It's not normal, but it is common. Okay. But the biggest thing I want you to know, it's heard during systole. Okay. Where is it heard? Where's the best place? Sternal border at the second or third intercostal space on the left side. Okay. All right, let's go on down. Hemorrhagic disease of the newborn. Okay, so we talked about vitamin K a while ago, right? Aquamaphytin. This is what we give at birth. Okay, the first few days of life, because the babies do not have that blood clotting factor when they're born. Okay, so we're going to help them out by giving them some vitamin K. Okay. So, wink and a lollipop. All babies are at risk for hemorrhagic disease, most often caused by vitamin K deficient bleeding. Okay. All right. Another wink and a lollipop. Vitamin Ks are at risk for vitamin K deficiency, such as intracranial hemorrhage, because of this lack of vitamin K, especially during vaginal births that can cause head trauma to the skull. Okay, so when doctors have to use forceps or some strong suctioning, we get really concerned about the trauma. Okay, we definitely don't want a baby to have a bleed because they don't have those blood clotting factors, right? And if the bleed happens before we can give the vitamin K, it can be a bad thing. So, all right, let's look on page 313. This is still under that same, let's see, let's go back up. Under that same vitamin K. in newborns, so you need to know this, in newborns, we're giving those injections IM, okay? Right here. IM, 1 to 2 hours after birth. It may be repeated. It's usually not repeated unless there's an issue, but we give the 0.5 to 1 milligram of vitamin K IM. Where do we give it? In the vastus lateralis, okay, which is also a wink and a lollipop. All right, so halfway down the vastus lateralis, all right, a wink and a lollipop. That muscle right here in the middle of their thigh, okay, straight down. I am 90 degrees. All right, and remember, I tell you to, if you'll always give the vitamin K in the left leg, say with your alphabet KL, you'll never forget where you gave it when you start a chart. Okay? Alright. If there's anything else over here I wanted you to look at. Cords. Alright, let's talk about cords for a second. This is just right here. It's in your book somewhere, but I want you to look at this, okay? So AVA cords, artery, vein, artery, okay? They stay clamped for up to 48 hours. They fall off within 10 to 14 days. You don't put anything on them, okay? You report any drainage. You report any edema, any redness, okay? So you instruct the patient or the patient's parents that, okay? Only clean with water. We used to put that purple dye on them to help them dry quicker, and it really didn't do anything but make a mess all over the baby. But you just clean them with water, okay? Let the parents know that they should not submerge the baby in a bath until after the cord has fallen off, okay? They're just kind of sponge bathing the baby until then. All right. Genitourinary findings. So when we're listening to the baby, we do just like adults, okay? We're going to look, listen, and then feel, okay? So all 4 quadrants. We're looking, then we're listening, and then we're feeling. Feel, laterally across the abdomen, all right? Genitourinary assessments, okay? So we're looking at the female, we're looking at the majora and minora, maybe exposed if the baby is predates, but a full-term baby's majora should cover the minora and the clitoris, okay? For a baby, a male baby, so we're checking to make sure that the spadius, the end of the urethra, is centered at the end of the penis. We're also checking the testicles to make sure that their testes are descended, that you can feel like the tiny little marbles on both sides. And we're also checking on both sexes for a patent anus, and that you see the wink there, okay? You see the little tiny wink at the anal opening to make sure it is patent, okay? We don't take rectal temperatures anymore unless something's majorly wrong, because of the risk of perforation to the bowels, to the intestines, okay? But we do check to make sure the anal is open and patent, okay? All right, for the baby boys, and see, this is a picture of the genitalia on the female. You see how the majora is covered, the minora, this is normal. This is vernix here, okay? And this is normal on a baby girl and a baby boy as far as the vernix is concerned, okay? We're not scrubbing this off. We're leaving this, okay, in here. We're scrubbing the leg part but in between the majora and the minora, we're not, that's called a smegma, we're not scrubbing that area, okay? If you look on page 315, you'll see these terms, hypospadias and epispadias, okay? Right here, this is a normal urethra end. The hypo, I remember hypo low, okay? It's underneath, all right? Severe hypospadias is right here where the testicles and the penis are conjoined, all right? So severe, major surgery going to have to happen here to extend this urethra all the way down to the tip of the penis, okay? This is a hypo, so it can be here, here, or here. And an epispadias would be on the top, all right? It is a congenital defect. It's when the tube fails to tubularize or go to the end of the penis, okay? And that it will cause sexual dysfunction, if left untreated, infertility, and of course some insecurities as well, okay? On page 317, it's just talking about the musculoskeletal system. We've kind of covered most of that. We do want to check for hip clicks, things of that nature, and the rooting, the different reflexes. You got a whole sheet of those, right? You remember that whole newborn reflex sheet? I expect you to know those and know exactly what I'm talking about when I say a Moro reflex, okay? Or a rooting reflex or startle reflex. What am I talking about? All right. And those are in your book on page 319 through 321. On page 317, it's talking about the Barlow test here. Just be familiar with this term. And then the Gazilli test. All right, and let me find it on here. Right here. And this is hip dysplasia, okay? Gazilli test, and it's also known as the ALIS test, all right? And this is just where you flex the knees up and then open up to see if you feel that hip click or anything. And you're testing for the hip dysplasia, okay? Developmental dysplasia of the hip is what DDH stands for. All right. Let's go back. Car seat challenge. For the quick, it's meaning the baby can sit on a monitor, on a telemonitor, telemetry monitor in a car seat with an O2 sat on, of course, as well, and not have any apneic spells for 1 hour, okay? If a baby's ever been on a monitor, they're going to have a car seat challenge done before they go home. If they've ever had any type of apneic or CPAP at birth, any apneic episodes, then they're going to have that car seat challenge ordered before they can go home, okay? All right, so let's look at, of course, you know how to suction, right? Remember, our babies are obligate nose breathers, so we want that nose cleared, but we always suction the mouth and then the nose, right? All right, let's go back and finish up chapter 9. So look on page 318. We're going to talk about syndactyly and polydactyly, okay? So polydactyly is where there's extra digits, okay? Be familiar with that term. And then syndactyly is where there's a webbing in between the fingers or the toes, okay? This is all of your reflexes, okay? Just be familiar with those. On page 323, care of the newborn, let's look under temperature assessment. This is a wink and a lollipop, okay? So, of course, it says the axillary skin method is reflective. I'm sorry, I'm trying to stop this. Is reflective of the infant's core temperature, okay? The body's compensatory response to the environment and is preferred non-invasive method that provides the closest estimation of the rectal temperature. Although rectal temperature is the best, it's the closest approximation to the core, it's not recommended due to the transmission of stool-borne pathogens, irritation, and of course perforation. Okay? Wink and a lollipop. Alright, let's look on page 325. This is talking about diapering, circumcisions, okay? So if you'll look at the very bottom of 325 on the left, it's talking about the plastibell. And I don't know if you remember me showing you that, but it's this little clear, this is actually clear plastibell. And that some of the pediatricians use when they do circumcisions, okay? It's a little bell rim that has a string on it, and it remains in place until it falls off in about 5 to 7 days. You do not have to use petroleum jelly for that, okay? Wink and a lollipop, though. Circumcision site should be assessed for every 30 minutes for at least 2 hours following the procedure, okay? It's important to observe the first voiding after the circumcision, okay, and bleeding after circumcision to evaluate urinary obstruction or penile injury or edema, okay. Parents should be taught the petroleum ointment should be placed on there, okay, directed by the physician. They should notice the swelling pus, the baby not urinating, okay. So we watch the babies in the nursery for at least an hour, okay, sometimes 2 hours. If the baby voids and they have the petroleum gauze on, not this, okay, this is a yelling clamp, and this is a plastibell. But if they just have just the gauze around the penis, if they void, it can stay on. If they have a bowel movement and it gets on the gauze needs to be changed, okay? They also need to report the first voiding after the baby has a circumcision, okay? They usually get circumcisions on the last day, right before they go home, but they have to void before they can leave the hospital, okay? Look on page 326, erythromycin. Okay, this is eye care. So we give erythromycin to prevent any bacteria from delivery that may get into the eyes, okay? Some streptococcus, some STDs, STIs, okay? So be familiar with this. This is a wink and a lollipop. Know this drug, okay? It's a prophylactis for the eyes for the baby, okay? The biggest thing that you need to know on this chart is 4 and 5. So you start with the inner canthus, and you move to the outer canthus. Dab the excess medication off gently, but do not wash it away. Once we put it on there, we leave it until it's time to bathe the baby, okay? It's very, very, very important for you not to touch the baby's eye with the tip of the ointment tube, okay? It's metal. it can scratch the baby's cornea. So you do not touch any part of the baby with that. You hold it up and away. You start with the inner canthus and go to the outer canthus without touching the baby. Okay? So, know that. Hepatitis B vaccine. It's important for you to know that the vaccine is given to newborns within 24 hours of birth for medically stable infants that weigh at least 2,000 grams. Okay, so they got to weigh at least 2,000 grams. Okay, patient education. So, promoting family attachment. Remember, I told you it's important for you to note the bonding. We chart that on our newborn shift assessment, nursery shift assessment. And it's important for you to note, is there bonding going on? Is the mama just leaving the baby in the bassinet, not feeding the baby? You have to keep reminding her to change the diapers. That can be an issue, okay? So we need to know, is there bonding occurring, okay? If you'll look at encouraging breastfeeding earlier with the appropriate education, feeding, teach the parents about feeding cues, okay? Rooting, sucking, if they're sucking on their fist or trying to suck on the mamas or turning their head to act like they're wanting to eat. This is important. This is winks and lollipops, okay? Also, one more is assure the parents to take the time to feel comfortable in meeting their needs, their newborn's needs, okay? Winks and lollipops, all right? Okay, last thing in this chapter, focus on safety. So we're going to talk about sudden infant death syndrome, or also known as sudden unexplained infant death, SUID now, okay? It's very important to educate the parents that we always put our babies back to sleep. So, always on their back, not on their side, not on their belly, to sleep. Now, they can have tummy time during the day, but they do not need to sleep on their backs because we are trying to decrease the sudden infant death syndrome, okay? So, winking a lollipop. Nurses can help meet this goal by teaching the parents placing newborn on their back to sleep. Okay? Also, another winking a lollipop. You're going to teach about infant safety by clearing the bed, right? Nothing should be in the bed. Alright? So, other actions to help reduce SIDS is they're sleeping on a firm mattress, okay? They're not sharing a bed with anybody else. They're not sleeping with mom and daddy. They don't have any loose objects in the bed. No big fluffy blankets. The only thing that they should have in their bed is maybe a pacifier and a bulb syringe. Okay? No bumpers, no blankets, nothing like that. Okay? They should be sleeping in a onesie to keep them warm enough. Okay? Alright, that is the end of chapter 9. I'm going to post this one and then I will continue on with chapter 10 in a minute.